While skeletal muscles drive ventilation, the autonomic nervous system fine-tunes airflow by regulating bronchiolar smooth muscle and secretions. This division of control allows for rapid reflexive responses to environmental and metabolic demands without really conscious input. And we're kind of seeing this here. We see the green is representing motor to skeletal muscle. The blue is representing parasympathetic and the red is representing sympathetic. So looking at our parasympathetic stimulation, the autonomic nervous system does not initiate breathing. It's important to know that, but it powerfully modulates airway resistance and secretions. Our parasympathetic and sympathetic inputs act primarily at the level of the bronchioles, where smooth muscle tone has the greatest impact on airflow. This allows the respiratory system to rapidly adjust ventilation in response to irritants, exercise, and metabolic demand without really conscious effort. When we think about then, let's see, I think I had one more slide here. Let me go back. We'll look here. So, our parasympathetic stimulation via muscarinic receptors causes bronchoconstriction and increased mucus secretions, which is appropriate for airway protection, but detrimental when excessive. Sympathetic stimulation, primarily through circulating epinephrine, acts on beta 2 receptors and it causes bronchodilation. This distinction helps explain why stress or exercise can temporarily improve airflow in obstructive lung disease. So when we think about this, when we're in a sympathetic state and we're trying to fight off something or run away from something, we increase our heart rate and we want to open up our airway to get more oxygenation. So that's how you think of our sympathetic stimulation and what it does. Now that we know this, asthma causes difficulty breathing due to inflammation and constriction of the bronchioles. So explain then why each of the following is used in its treatment. Albuterol, which is a beta 2 agonist, ipratropium bromide, which is a muscarinic antagonist, and fluticasone, which is anti-inflammatory and a corticosteroid. Well, asthma as a condition is characterized by inflammation, bronchoconstriction, and mucus hypersecretion. Albuterol, being a beta 2 agonist, directly will bind to beta receptors and act similarly. So it's going to lead to bronchiolar smooth muscle relaxation. Ipratropium bromide is going to block parasympathetic muscarinic receptors, which is going to decrease bronchoconstriction, and it's going to decrease secretions. And then lastly, fluticasone is anti-inflammatory, so it's going to address the underlying inflammatory process, decreasing airway hyperresponsiveness over time. Effective asthma management requires targeting all three mechanisms, not necessarily pharmacologically, but or using a pharmaceutical, but addressing all three mechanisms in some way. Now that we've looked at more kind of the microscopic physiology, we're going to transition and look a little bit at some macroscopic lung anatomy, shifting our focus from airflow control to lung structure, vascular supply, and mechanical support.